As a practical matter, we know that RAS testing takes longer in certain academic centers versus community centers. And so we certainly don't recommend waiting for a patient to start chemotherapy to obtain RAS status, because the base chemotherapy is going to be the same, and that's really the main part of the treatment. So I think it's personally very reasonable to start the patient on their chemotherapy regimen, whatever your choice is, FOLFOX, FOLFIRI, and depending on RAS status, you can add in either the EGFR inhibitor or the VEGF inhibitor, depending on whether they're wild type or mutated. I don't think we have to wait for that result to start the patient who's sitting around and waiting to be started on what is the standard of care of chemotherapy. So as a matter of practice, even in academic centers, sometimes it can take far too long for these tissues to come back, tissue results to come back. So we start the patients on chemotherapy unless you are required to as part of a clinical trial. For right-sided tumors, we know that the role of EGFR inhibitors is less clear. We know that the benefit of EGFR inhibitors is very much greater in left-sided tumors versus right-sided tumors. So the questions come up, should we bother even knowing RAS status in the right side if you have no intention to use that drug in the right side? I would say yes, though, for two reasons. One, I do think EGFR inhibitors have a role in right-sided tumors, albeit a much smaller role than they do in left-sided tumors. And also, RAS status, knowing RAS status helps you plan out that treatment program for the next few years, whether it is for clinical trial options or otherwise. So I think even though in right-sided tumors there's less benefit from EGFR inhibitor, I still think it's good to know whether they're RAS wild type or RAS mutated. RAS status is very important to know, not just for what you're treating the patient with now, but also what your plans are for the patient over the next few years. I think that when we look at trying to get a complete picture of what's going on with the patient, we should try to know RAS status, not only because we may choose to use an EGFR inhibitor or not. That's a personal choice depending on the situation of the patient and the data that supports it. But independent of that, it helps determine what's going to be that patient's treatment course down the road, whether it be second line or third line or eligibility for clinical trials. So I'm a big believer in you have to know the status. Even if you're going to use bevacizumab all the way through, you should still know what the RAS status is of that patient. It provides a complete package. So I do think it's essential to know that status, even if hypothetically you have no intention of using the drug till later. So retesting RAS at progression is still controversial. There's some new data that suggests that there are certain clones that are lost, and some patients who develop resistance to an EGFR inhibitor, for example, have now acquired, some of the remainder cells have acquired a RAS mutation, and that's been shown in a number of preclinical and even clinical trials. So I don't do it routinely unless it's mandated on a clinical trial to retest the RAS status. What we're seeing now more and more on that topic is the use of these liquid profiling assays that are a little bit easier to do, get the results perhaps a little faster. And for something like RAS status, actually the newer liquid next generation sequencing testing are very comprehensive. So meaning that the sensitivity of picking up a RAS mutation in the blood is pretty good as it relates to something like KRAS. So I think more and more we're going to start seeing those incorporated in various time points during the patient's progression to see how it correlates with their initial status.